In this video, I'm going to talk about different gastric disorders, first starting with the discussion of the function of the different gastric hormones, then discussing the risk factors to acute gastritis versus chronic gastritis, discuss the different forms of peptic ulcer disease, the mechanism of toxicity of Helicobacter pylori, the diagnosis test, as well as the treatment options, then discuss how different forms of peptic ulcers can cause bleeding from different sites, discuss the function of different ulcer medications, discuss different stomach cancers, their sites of metastasis, as well as Zollinger-Ellison and Menetrier's disease. So first, starting with different hormones, the first point that you will have to know here is that which of these GI cells are producing the hormones that are listed here. So I've come up with a mnemonic to make it easy for you. So with the gastrin, it's easy. Gastrin is being produced by the G cells. With somatostatin, soma goes for summer days. So somatostatin is being produced by D cells. So summer days, and then D goes for D cells. And this hormone is actually being produced by the pancreas, so I would like to remind you that the alpha cells of the pancreas were the cells that were producing glucagon, while beta cells were the cells that were producing insulin. And now somatostatin is being produced by the D cells of the pancreas, which decrease gastric and pancreatic secretions and also decrease the gallbladder contractions. The next hormone is secretin, which is being produced by the S cells. Cholecystokinin, the way I remember it is that there are two I's there, so cholecystokinin is associated with the production by the I cells. Gastric inhibitory peptide, or GIP, the mnemonic that I have for you is GIP-Keys. So GIP goes for GIP, and then Keys goes for the K cells that produce gastric inhibitory peptide. And then finally motilin, which increases the gastric motility of the GI tract. So here I've listed the function of all these hormones, which you can go through, but there are a few important points that I would like you to know. And one is that cholecystokinin is the hormone that causes increased gallbladder contractions. So in patients, for instance, that have cholelithiasis, where there are gallstones that are present in the gallbladder, after these patients are eating fatty foods, what happens is that there is secretion of cholecystokinin, which causes increased gallbladder contractions, and at that point the patient will start to complain of an abdominal pain. So if a patient has cholelithiasis, eats a fatty food, what hormone induces the abdominal pain in these patients is the cholecystokinin, which causes the increased gallbladder contractions. I would also like you to know the factors that increase or decrease the gastric acid secretion. So gastric acid, its secretion can be increased by factors like, for instance, histamine, and it's via the H2 receptor. So the way I remember it is that acid reminds me of similar to H2O. So the H2 receptor of the histamine is the one that induces the acid secretion. It's also being induced its secretion by gastrin and vagal stimulation, which increases the acetylcholine. And then the levels decrease by somatostatin, gastric inhibitory peptide, secretin, as well as prostaglandins. Alright, now the first condition is gastritis, and I would like to go over the risk factors to acute versus chronic gastritis. So conditions that will disrupt the mucosal barriers will cause inflammation of the stomach or gastritis, and these conditions include, for instance, stress, alcoholism, NSAIDs like ibuprofen. And what these medications do is that they decrease the secretion of prostaglandins by inhibiting the COX enzyme, and so prostaglandin is the factor that will help maintain the mucosa of the GI tract. And so if the prostaglandin is destroyed, therefore these patients are prone to losing their gastric mucosa and start to develop inflammation. Burns, what burns do is that it will decrease the plasma volume, as a consequence of which there would be decreased blood flow to the stomach, and thus these patients will develop sloughing of the gastric mucosa. And finally, brain injury. What it does is that it can increase the intracranial pressure, which increases the vagus stimulation. Therefore, there would be increased acetylcholine secretion, which will increase the gastric acid secretion, and thus it again can lead to development of gastritis. So here, this type of ulcer that is produced by burns is referred to as Curling's ulcer, while the ones that are caused by brain injury are referred to as Cushing's ulcer. The next form of gastritis is chronic gastritis, which is divided into two types, type A and type B. So type A is caused by autoimmune reaction. So type A is caused by autoimmune reaction, where there are autoantibodies that are formed against parietal cells. And the function of parietal cells is one, to produce the gastric acid, and the other function is to produce the intrinsic factor, which is important for the absorption of vitamin B12. So if the parietal cells are targeted in type A chronic gastritis, therefore these patients will develop achlorhydria, as well as pernicious anemia because of the loss of the intrinsic factor. And then this type of chronic gastritis is more commonly affecting the body and the fundus of the stomach. And then type B is mostly associated with the Helicobacter pylori infection and is affecting the antrum of the stomach. So the memory aid that I have for you is A times B versus B times A rule. So type A chronic gastritis affects the body. So type A affects the body. And then type B affects the antrum of the stomach. Now, if you have problem memorizing the order of the stomach components, the names that are shown here, again, another mnemonic that I have for you is called A, B, C. So here we have the antrum, A, then we have the body, and then we have the cardia, C. So A, B, C. And you already got 3 of them out of the way. And then we have fundus on the top, pylorus in the end. The next condition is different forms of peptic ulcers, which are divided into gastric ulcers as well as duodenal ulcers. So here I've provided with some mnemonics. So G can help you remember that the pain becomes greater after meals. So G, gastric ulcers, the pain is greater after meals. So these patients are usually losing weight because they try to avoid eating foods. While with duodenal ulcers, the pain decreases with meals, and then it becomes worse 2 to 3 hours after meals. So again, since it initially causes a decrease in pain, so these patients will increase their eating habits, and so they can gain weight. There is also association with gastric ulcer, has been shown to be associated with blood type A, while the duodenal ulcer has been shown to be associated with blood type O. Common causes of gastric ulcer include Helicobacter pylori infection, as well as NSAIDs, which will inhibit the production of prostaglandin, which is required for the maintenance of the gastric mucosa. And then with the duodenal ulcer, Helicobacter pylori, as well as Zollinger-Ellison syndrome are common causes of duodenal ulcers. And then acid secretion in gastric ulcers is usually normal to low, while with the duodenal ulcer, it's normal to high. As a consequence of which, there is usually hypertrophy of the Brunner's glands. So Brunner glands are the glands in the duodenum that are producing the alkaline solution. So if there is too much secretion of the gastric acid, therefore there would be hypertrophy of the Brunner glands to produce more alkaline solution and neutralize the gastric acid. And then finally, the risk of carcinoma in gastric ulcer is increased, but in duodenal ulcer it's usually benign. Okay, next I would like to go over the pathophysiology of the Helicobacter pylori infection. And what Helicobacter pylori does is that it produces ammonia through the function of the urease. And what ammonia does is that it neutralizes the local acid environment, and so the bacterium would be able to survive now inside the stomach. And then the bacterium will penetrate the mucosa and cause bleeding ulcers. And at the same time, Helicobacter pylori, what it does is that it inhibits the somatin, as a consequence of which there would be an increased gastrin secretion, and thus there would be also increased gastric acid production. So these patients usually develop increased gastric acid with gastric metaplasia. Complications that can arise in these patients include, for instance, peptic ulcers, which I just discussed with you, intestinal type stomach adenocarcinoma, and I will go over the difference between intestinal type versus diffuse type stomach cancers. And then it can also cause MALT lymphomas, where there is a gastric mucosa associated lymphoma. And then for the diagnosis, you can order the urease breath test. So since the Helicobacter pylori is a urease positive organism, the breath test would be positive for urease. And then you can also order serum IgG antibodies against Helicobacter pylori. You can check for stool antigen. And then finally, you can diagnose by endoscopic biopsy. For the treatment, what you will have to do is that you will have to provide 1 proton pump inhibitors, like for instance omeprazole, plus 2 different antibiotics. So here are the 2 selections that you can have, the 2 choices of the medications that you can prescribe. So I've come up with a memory aid for you. The first one is called O-CLAM. So O goes for omeprazole, CLAM, CL, goes for clarithromycin, and then AM goes for amoxicillin. And then for the other one, O-metrocycle, O again goes for omeprazole, metro goes for metronidazole, and then cycle goes for tetracycline. Now, it's important to note that the gastric ulcers can cause bleeding, and so it depends on where the site of the gastric ulcer is, and thus it would be bleeding from different vessels, and you will need to be familiar with those. So if there is right in the posterior wall of the stomach, then the bleeding would be from the splenic artery. If it's in the lesser curvature of the stomach, then the bleeding would be from the left gastric artery. And then with the posterior erosion of the duodenum, there is bleeding from the gastroduodenal artery. So with the duodenum, it has to be from the posterior duodenum to affect the gastroduodenal artery and cause bleeding, while the anterior duodenum erosion can lead to perforation. So therefore, it's the posterior duodenum that leads to the bleeding from the gastroduodenal artery. Now, there are different medications that you can use to treat the gastric ulcers, starting with antacids. For instance, we have magnesium hydroxide. And you should be aware that magnesium hydroxide can also cause diarrhea. So the memory aid that I have for you is that magnesium causes maximum fecal output. You can also provide these patients with the aluminum hydroxide, and aluminum hydroxide side effect is constipation. And again, the mnemonic that I have for you is that aluminum causes minimum fecal output. And then calcium bicarbonate would be the final option that is also available to use as an antacid. And you should know that the calcium bicarbonate will interfere with the absorption of the tetracyclines. The next classes of medications are histamine H2 antagonists. So as I mentioned earlier, it's the H2 receptor that causes increased gastric acid secretion. So example of histamine H2 antagonists include, for instance, cimetidine, ranitidine, famotidine, and so on. And so the side effect of cimetidine, which you should be familiar with, include the anti-androgenic effects. So these patients develop gynecomastia, and it also inhibits the function of the P450 enzyme. The next classes of medications are proton pump inhibitors, like for instance omeprazole and pantoprazole. And the way these medications work is that they inhibit the hydrogen potassium ATPase pump, and thus the hydrochloride can no longer be secreted in the stomach. So for the same reason, the side effects of these medications include increased risk of the pneumonia, as well as C. difficile infection. So since there is less stomach acid, therefore the environment of the stomach is less harsh to these bacteria and they can grow, and so there is an increased risk of infection with these agents. Reduced stomach acid also interferes with the calcium absorption, so there is increased risk of hip fractures associated with proton pump inhibitors. And then finally, patients can develop hypomagnesia, and it's again from the reduced stomach absorption of the magnesium that these patients develop hypomagnesia. The next classes of medications are mucosal protective agents, examples of which include sucralfate and bismuth. And these medications form a protective coating over the ulcer bed. And then the next medication, which functions through the same mechanism by providing mucosal protection, is the misoprostol, which is prostaglandin E1. And what this medication does is that it increases the production of the mucous barrier and it decreases the production of gastric acid. So just know that these two classes of medications, both of them function through the same mechanism, and that is to protect the mucosa. And then finally, antibiotics are used to eradicate the Helicobacter pylori infection. And I just discussed that with you. The mnemonics that we have are O-clam and O-metrocycle. So O's goes for omeprazole, which is a proton pump inhibitors, and then with the clam goes for clarithromycin and amoxicillin, or you can use metronidazole and tetracycline for eradication of Helicobacter pylori. Next, I would like to go over the stomach adenocarcinomas. So I mentioned earlier that the complication of Helicobacter pylori is the development of the intestinal type stomach adenocarcinoma. So the risk factor to this type include, as I just mentioned, Helicobacter pylori infection, autoimmune gastritis, or in other words, type A, consumption of dietary nitrosamines, which are found in the smoked foods, as well as finally blood type A. All of these are risk factors to the development of the intestinal type stomach adenocarcinoma. And this type of cancer usually affects the lesser curvature of the stomach. So if here was the stomach, here is the greater curvature versus the lesser curvature shown right here. So intestinal type usually affects the lesser curvature of the stomach. And then examination of these lesions shows large ulcers with heaped margins. Next, we have the diffuse type adenocarcinoma, which is characterized by the presence of the signet ring cells, as well as lineatus plastica, which goes for the thick leathery stomach wall. So with the signet ring cells, what happens is that these cells are producing so much mucus that it pushes the nucleus to the side. So if here is the cell, the nucleus will be pushed to the side and the rest is all filled with the mucus. So it has a ring-shaped appearance, and so it's referred to signet ring cells. And then unlike intestinal type, the diffuse type is not associated with the Helicobacter pylori infection, but it's thought that the mutations in the E-cadherin gene may be a factor that triggers this type of stomach cancer. And then stomach cancer can metastasize to different sites, and you will have to be familiar with the terminology. So with the Virchow's node, the metastasis has gone to the supraclavicular node. So here we have the clavicles, and then here is a supraclavicular node that has been affected. And then with the Krukenberg's tumor, the ovaries are invaded, and on histology you will see a lot of mucus as well as signet ring cells. And then finally, with the Sister Mary Joseph nodule, there is subcutaneous periumbilical metastasis. So around the umbilicus, that's where you will see the lesions. The next condition is Zollinger-Ellison syndrome, which, as I just discussed earlier, is a common cause of a duodenal ulcer, and it's being caused by a gastrin producing tumor that is usually in the duodenum or the pancreas, and thus it will increase the gastric acid secretion. So as I just discussed earlier, Brunner gland is located in the duodenal submucosa and it secretes an alkaline mucus. So in these patients, since there is too much gastric acid secretion, there will be hypertrophy of Brunner's glands. And then one very other important feature of Zollinger-Ellison syndrome is that there is thickening of gastric mucosa. The final condition that I'm going to discuss with you is the Menetrier disease, which is a rare acquired condition of the stomach that usually affects the middle-aged men, and these patients present with anorexia, nausea and vomiting, as well as epigastric pain. So while the exact pathophysiology of this disorder is not known, it's thought that the overproduction of the transforming growth factor alpha is what causes the increased signaling of the epidermal growth factor receptor that causes proliferation of the epithelial cells of the mucous cells that leads to the hypertrophy of the stomach folds. And then at the same time, this TGF-alpha, what it does is that it inhibits the gastric acid production and cause atrophy of the parietal cells. So the important features that you will have to know about Menetrier's disease, also known as protein-losing hypertrophic gastrophy, is that 1. There is a proliferation of the mucous cells. 2. There is hypertrophy of the gastric folds. 3. There is atrophy of the parietal cells. 4. There is hypoalbuminemia, as a consequence of which the name protein losing has been given to this disorder, and thus these patients can develop edema as well as ascites. And then the final feature is increased risk of gastric carcinoma. And that concludes our discussion of the gastric disorders.